about kidney disease in patients with liver disease. Actually, as you know, kidney disease and liver disease, the interaction, that is one of my, I'm very keen about this area and very interested for it. So I will talk briefly about the kidney diseases in patient with liver disease. Liver and kidney, they interact with each other. And why they interact? Liver disease can lead to kidney disease, and similarly, kidney disease can lead to liver disease. So both are interacting with each other. Because if you see, there are only two organs in the body which filter the entire blood. One is liver, another is kidney. So both are interacting with each other. Once any toxin, most of the toxin in our body, 90% in whatever form, they enter through the GI tract. And liver is the first organ which is going to filter it, stop it, and later on, whatever toxins are left over, it is handled by the kidney. Kidney is handling most of the time endogenous toxins, and liver is handling most of the exogenous toxins. So both are the organs which handles the toxins and other agents which damage our body. So it's logical that they should interact with each other. I will limit myself only to the diseases where the liver disease is leading to kidney disease, but I will not talk about the kidney diseases leading to liver disease, which my colleague Dr. Arka will talk about. So there could be different type of group of diseases where liver and kidney can be affected. One of the condition could be where there's a third factor, third agent which affect liver and kidney simultaneously, like diabetes, which causes fatty liver, which causes diabetic nephropathy, hypertension, which is associated with fatty liver, NASH, and hypertensive nephropathy. There can be Wilson disease, which is primarily a liver disease. Pathology is in liver, but it can also affect kidney because of copper and toxicities, amyloidosis. So all this kind of disease I will not be talking about. There can be diseases where liver is cirrhotic. That's why I have made this liver in form of clouds. It's cirrhotic nodular liver, which affect kidney, as Madam told very clearly. It's hepatorenal syndrome, acute kidney injury. Those are very well known that when liver is cirrhotic, it causes hemodynamic disturbance. There's pooling of blood in splanchnic circulation, relative hypovolemia in arterial system, leading to vasoconstriction in renal arteries and hepatorenal syndrome. I will not talk about acute kidney injury related cirrhosis, hepatorenal syndrome, or acute liver failure related acute kidney injury, because most of the time these are the acute illnesses. And here the probably nutrition is omitted most of the time. If you are not going to transplant patient with hepatorenal syndrome, the chances of reversal and long-term survival, where nutrition can play some role, is less likely. I will restrict myself to few topics where the liver is almost normal or having chronic liver disease, but non-cirrhosis, were leading to kidney injury. And these are the three common conditions: fatty liver disease, hepatitis B virus, and hepatitis C virus, where liver disease lead to kidney disease. I will take one by one. Before I move to etiology, I would like to talk briefly about association and causation. Most of the studies, when we are doing not a prospective study, not a cohort study, a cross-sectional study, when we are doing, we are getting two factors associated, like hepatitis B virus with the chronic kidney disease. So it is association, but every association does not mean a causation. There can be reverse causation also. To prove that an association is actually representing a causation, there are criteria which is called Bradford-Hill criteria. These are the 9 criteria, and the larger number of criteria are fulfilled in any condition, there is a stronger evidence that this association is actually causation. But there's no absolute number of criteria which has to be present. to define association as causation. One is temporality. That means the cause should come first, followed by effect. Strength of association. Consistency means the association is in the same direction in different studies conducted in different group of population, in different setting, different countries, regions, etc. There should be a biological gradient, means a dose response relationship between the cause and the effect. Specificity means a cause causing certain specific diseases. Biological plausibility means you should be able to explain this association based on the existing knowledge about the cause and the outcome. It should be coherent, means our association should not be going against the available biological evidence of association. There can be experimental evidence, means if we have removed the cause, the effect should show some degree of reversal or complete reversal. And there should be analogy of this association in literature in relation with some other disease. So I will apply these criteria for chronic hepatitis B and chronic kidney disease. This was the first study published in 2015, which strongly showed that hepatitis B lead to chronic kidney disease. This database was the health insurance database of Taiwan, which included around 18,000 adult patients with chronic hepatitis B. And please note, these participants were not on antiviral drug. So kidney disease cannot be attributed to the antiviral drug tenofovir, which can lead to proteinuria or reduction in GFR. It was matched in 1:4 ratio with 71,000 randomly selected controls, which were age and gender match. And both the cohorts were followed till the first diagnosis of chronic kidney disease using standard criteria. And please mind, this was without ESRD, means chronic kidney disease up to stage 1, proteinuria, stage 1, stage 2, 3, 4, but not ESRD. Death or end of 2010, whatever comes first, the follow-up was stopped. And this was very interesting data you see here. With each year, people with HBV had higher incidence of chronic kidney disease as compared to their non-HBV comparator. At 1 year, 3 year, 5 year, 7 year, 9 year, 11 year, and 13 year, at every level, you will see that the risk of or incidence of chronic kidney disease was higher in HBV cohort as compared to non-HBV cohort. And the second important observation in this table is biological gradient, which we just talked about. With every year, the risk of chronic kidney disease was increasing for the cohort of HBV as well as non-HBV. So this is very important observation. This study showed about temporality because it was a prospective cohort study. Strength of association is good. Ratio is up to 2.5. Risk of incidence of chronic kidney disease in those with HBV as compared to those with no HBV. Result is consistent in different studies, but not in this study, you can say, and biological gradient. The same result shown as survival analysis, that the cumulative incidence of chronic kidney disease was consistently higher at all year of follow-up in HBV cohort as compared to non-HBV. The same cohort, they had actually published 2 papers. First paper was this one, and second paper was here, where the ESRD group was taken separately, that the risk incidence of end-stage renal disease between HBV and non-HBV, and the same pattern of consistent biological gradient we have found that for all the year of follow-up, 2 year, 4, 6, 8, 10, and 12, the risk of ESRD was higher in HBV cohort as compared to non-HBV. Same values shown here. This is an important observation of this study. They have divided the incidence of ESRD according to the gender. For men, which is on the left side of the panel, You can see for the age group less than 60 or more than 60. Less than 60 is black colored line, and the dotted line are showing HBV cohort, and the continuous line is showing non-HBV cohort. So if you see in the left panel, in both the age categories, means black dotted one has to be compared with the black solid line, and the red dotted line has to be compared with the red solid line. We can see that for all the age group less than 60 and more than 60, the risk of ESRD was higher in HBV cohort in men as compared to non-HBV cohort. But this was not true for women. For women, it was very interesting. For age more than 60 years, there was no difference in incidence of ESRD between HBV and non-HBV cohort. But for less than 60, again, the risk of ESRD was higher in HBV cohort as compared to non-HBV cohort. So the association might be different for different gender. This is another study from rural China, very large study. That's why I have included it. Included multi-stage random sampling of 3 million population from entire China, from 31 provinces. Such a large study. And they have shown the different stages of HBV. Chronic hepatitis B is a continuation of infection. It ranges from immune tolerant phase, E positive disease, E negative disease. So it has shown that as the stage changes, the prevalence of different form of chronic kidney disease like hematuria, proteinuria, reduction in GFR, and chronic kidney disease, they increases with the increasing ages. But here, the effect could be the duration of HBV infection, because as the stage changes, the duration of HBV infection also changes. But here it seems to show some association between the stage of disease of HBV infection and the prevalence of chronic kidney disease. Here we can see a gradient. The same data is shown here, that as compared to non-HBV, HBV immunotolerant phase have 1.23 times odd ratio for chronic kidney disease. And this ratio is gradually increasing with progression of HBV disease. Now, if we see the systematic review and the meta-analysis, most recent one, which was done by Fabrizi, he is the person who has done maximum work in relation with viral hepatitis in chronic kidney disease. It included different type of studies, cohort study, case control, and cross-sectional studies. And outcome was seen as incidence of prevalence of chronic kidney disease, proteinuria, included 33 studies of around 4.6 million population participant. Different type of studies you can see here, they have included, and the incidence of chronic kidney disease in HBV infected population was approximately 1.4 times as compared to non-HBV population. But the prevalence was not different. The reason for this difference could be incidence is measured in cohort studies which are better quality, better organized, and prevalence is measured with the cross-sectional studies where we are following the patient, not following the patient, and just measuring the parameter outcome in one go. And they are not considered to be of that good quality. So that could be the reason for not finding any difference in prevalence of CKD in HBV versus non-HBV, but the incidence was higher and estimated adjusted hazard ratio was 1.4, which is significant. The risk factor for HBV-related chronic kidney disease are male gender, younger age, and E positive status. And the manifestation could be in form of membranous nephropathy, membranoproliferative glomerulonephritis, MPGN, IgA nephropathy, serum sickness-like syndrome, polyarteritis nodosa, lupus nephritis, crysenteric glomerulonephritis, FSGN, and minimal change disease. So there could be the different type of manifestations. These are the histopathological manifestations, but ultimately they are all the part of chronic kidney disease. The pathogenesis could be related to the deposition of circulating antigen antibody complexes in mesangium and some endothelial space of the capillaries. Could be the cytopathic effect of virus, which is less likely on the renal cell. It can be the virus-induced immune system, which is acting against certain antigens located on the renal cells. It can be the indirect effect of virus-induced cytokines due to inflammation, which might be the mediating the injury to the kidney. And there can be genetic predisposition to develop chronic kidney disease in people with HBV infection. We don't know the real mechanism. The mechanism is best known in relation with HCV, but not good known in relation with HBV. So if we summarize the evidence according to the Bradfield-Hill criteria, there are evidences to support temporality, to support strength of association. Results are consistent across different studies, studies done in different regions, different countries. There seems to be biological gradient, and there is likely biological plausibility, but we don't have evidence which is coherent, because in somewhere we are getting association in cohort studies but not getting in cross-sectional studies. So result is little bit incoherent. Inconsistent result, different design, lack of experimental evidence. We have not shown that if Hep B is controlled, then the CKD is reversed. So there's no evidence basis on experiment, and there is no evidence from analog. So there's some evidence to support that chronic Hep B could be a cause for chronic kidney disease. Now I'll move to HCV. Chronic hepatitis C, for decades, it's known to cause chronic kidney disease, and most common involvement is renal involvement as part of cryoglobulinic vasculitis, which affect medium and small vessels, including renal vessels, leading to membranoproliferative glomerulonephritis type 1, typically. And the treatment is anti-HCV drug. Even in era of peginterferon, they were treated with peginterferon and ribavirin. Now it is treated with DA, immunosuppression, with steroid, usually immunosuppression, which are used mycophenolate for renal transplant patient, and rituximab, and even higher immunosuppression are needed if it is not controlled. But there can be independent renal involvement, not at the part of cryoglobulinemia. This can take any form of chronic kidney disease like diffuse or focal MPGN, mesangial-proliferative glomerulonephritis, tubulointerstitial nephritis, membranous disease, IgA nephropathy, thrombotic microangiopathy, and FSGN, and any other form of chronic kidney disease. These are the just few which I have enumerated here. Ultimately, they form a spectrum of chronic kidney disease. I will not take individual study because we have a very recent systematic review where the association of hepatitis C virus and chronic kidney disease was assessed, again by Fabrizi, more than 4 million participants, and data from 40 studies. Here, the incidence of chronic kidney disease, hazard ratio for incidence for chronic kidney disease in prospective studies were 1.54. And it was consistent in different areas like US, Asia. Prevalence of chronic kidney disease was not that much strongly associated with HCV. Again, the same problem which we have just learned in relation with Hep B, because incidence we are measured in prospective cohort studies where the data collection is better, they are better quality studies, and the prevalence we are typically measuring in cross-sectional studies where there can be several factors. Proteinuria was higher, and the adjusted hazard ratio was 1.63 for HCV infected patient as compared to non-HCV positive patient. And here we have beautiful evidence, because in recent era, hepatitis C treatment is revolutionized, and now across the world, Hep C is treated with sofosbuvir-based treatment, which is given for 3 months to 6 months. And there are several studies. I have just quoted one of the good study, that sofosbuvir treatment lead to improvement in estimated GFR. And the median improvement in GFR was 9.3 ml. So here we can say there is evidence from experiment that we have removed the cause and the effect is reversed. The pathogenesis for SCV-related chronic kidney disease could be the deposition of SCV-related proteins, deposition of immune complex, antigen-antibody complex, or deposition of cryoglobulin in the mesangium. All this could lead to chronic kidney disease. So if we again reiterate our Bradford Hill criteria, that we have data to support temporality, strength of association seems to be reasonably good, we have consistent result, biological plausibility is there, and we have evidence from experiment design, but we don't have any data relation to biological gradient, which was there for HBV. There is lack of coherence, means the result is not consistent from all the studies. Different study design is showing different type of result, like cross-sectional study and cohort study, and there's no evidence from analogy. Now I'll move to NAFLD and chronic kidney disease, which is the most recent pandemic, metabolic pandemic of the world. It is really a disease which affect all the organ system, starting from brain, obstructive sleep apnea, malignancy, GI tract, kidney disease, heart, name any organ system, and all of them are affected in fatty liver disease. How the liver and kidney are interacting and how the liver disease is leading to kidney disease in these patients, there can be intricate mechanism, very large reviews, numerous hypotheses, and these are the most common pathogenic agents where the fatty liver lead to chronic kidney disease. The fructose, one of the main causative agents for fatty liver disease, it lead to chronic kidney disease, inflammation, oxidative stress, dyslipidemia, lipid toxicity, insulin resistance, and activation of renin-angiotensin system. So these are the main agents which have been considered as a link for fatty liver disease leading to chronic kidney disease. I will not go into the detail. And again, the data, how strongly they're supported. This meta-analysis was published in 2014, which included 64,000 participants and 16 population-based study and 17 hospital-based studies. This is interesting to see that fatty liver disease is diagnosed by three ways, either by ultrasound, CT scan, basically imaging, by histopathology, and by ALT-AST, which suggests NASH. By all the three categories of diagnosing NAFLD, you can see that the risk of incidence of chronic kidney disease, uh, uh, prevalence of chronic kidney disease was higher in fatty liver disease as compared to non-fatty liver counterpart. It was risk was 2.04, 2.77, and 1.86. Overall, the risk was 2. So the patient with fatty liver disease are at least double risk of developing chronic kidney disease as compared to those with normal liver. That was the prevalence. This is the incidence. The rate of developing chronic kidney disease is again higher. Taking any of the criteria to diagnose fatty liver disease, overall it was 1.8, which suggests that they are fatty liver disease people are at higher risk to develop chronic kidney disease. This was important subgroup analysis where the Fatty liver disease, we know it is a spectrum. It can be simple steatosis or it can be coupled with inflammation, which is called as NASH. So they have compared subgroup analysis where the NASH was compared versus steatosis within the fatty liver disease. And we can see that the risk of chronic kidney disease, prevalence of chronic kidney disease was higher in NASH as compared to those with simple steatosis. And this was 2.5 times. Another subgroup analysis where the within NASH, if you see, there can be advanced fibrosis and there cannot be significant fibrosis. So people with advanced fibrosis were at much higher risk to develop chronic kidney disease as compared to those without advanced fibrosis. All these subgroup analysis support biological gradients between the cause and effect. Here, the same data for incidence of chronic kidney disease that was for prevalence. So we can say that fatty liver disease seems to be associated with the chronic kidney disease. This is the most recent meta-analysis published in January 22 in Gut. And that's why I can't leave it. They have specifically examined the association between fatty liver disease and risk of incidence CKD of stage 3 or more, where the clinicians are most worried. Probably when the disease of CKD is in range stage 3 or 4, we are more worried. They have also attempted to examine the association between severity of NAFLD and risk of CKD stage 3 or more, but the data was insufficient, so they could not pool the results. They included 13 studies and see the number of participants. It was quite huge, 1.2 million participants. Out of these 1.2 million, 337,000 had NAFLD. So quite a large data. Here again, you can see the incidence of chronic kidney disease was 1.43 times in people with fatty liver disease as compared to non-fatty liver disease. They have also grouped this risk according to the method used to diagnose fatty liver disease. This is needed anyway because there is variation in diagnosis of chronic kidney NAFLD. So we can say that NAFLD is associated with high risk of incidence, prevalence, and severity of chronic kidney disease. And NASH-related cirrhosis carries a high risk of renal failure. This is from literature, not from the data we have just discussed. So for NAFLD and CKD, we have literature to support temporality, a good strength of association, consistency, biological plausibility. Experimental evidence is lacking. This is typographic error. Fifth point is my typographic error. We have biological gradient and we have coherence of evidence. So I can summarize that chronic liver disease is associated with risk of chronic kidney disease. The evidence is strongest for fatty liver disease because it is a recent disease and people are more and more studying the association of liver and kidney disease. Probably that's why we have a stronger evidence, followed by HBV and SCV. But SCV is most widely accepted and known risk factor for chronic kidney disease among all the three. All those with chronic liver disease due to HBV, SCV, or fatty liver disease should be regularly screened for the evidence of kidney injury, probably more frequently as compared to other people. So that's all I want to talk about this association. And if there is any question, I will like to